welcome you all to this webinar. It is 8th of the series, which is co-hosted by Community Health Community of Practice and Asia Pacific Observatory on Health System and Policy. I'm Sangeeta Bhattacharya, and I'm leading this initiative of the Community of Practice, and I'm based in India. So, as most of you know, being a member of this Community of Practice, it is just over a year that this community was launched, which is supported by UNICEF and USAID. Now we are a very strong collaborative platform with 400 plus experts, primarily from Global South. And the key objective of this platform is for better cross-country sharing, learning, and problem solving among practitioners, program managers, and academia. So those who are yet to join this network, but is part of this webinar, we will really urge you to do so. So more the voice, it's much better. The Asia Pacific Observatory on Health System and Policies is a collaborative partnership that promotes evidence-informed health policy regionally and in all countries in the Asia Pacific region. It was launched in 2011, and APO is currently hosted by the World Health Organization's Regional Office for Southeast Asia. APO brings together interested government, international agencies, foundations, and researchers with the aim of bridging the gap between scientific analysis and health system decision making. We are very happy that we could collaborate for this very topical theme of how community health workers can be engaged in the management and prevention of non-communicable disease, with findings from 4 countries in Asia, which includes China, Bangladesh, Nepal, and Vietnam. This topic is particularly relevant as most of us visualize CHWs as an agent for only reproductive, maternal, and child health services. But as countries are economically transiting, so the disease burden is also shifting. And as part of primary health care, there is an urgent call for integrating NCDs into CHW's portfolio. So we feel this webinar is very timely to hear example of strategies, practices, and approach from the 4 countries which are at different health system level. We are very happy to have 3 eminent speakers. We have Dr. Abu Saleh Abdullah, who is a research professor at the Global Institute and professor of global health at Hunshan University in China. Professor Abdullah is a behavioral scientist and public health physician with expertise in epidemiological studies, behavioral intervention, and health service and system research. And his current research interests include prevention and control of chronic NCDs in LMICS. We have Dr. Lal Rawal, who is a senior lecturer and also an adjunct fellow at Western Sydney University in Australia. Dr. Rawal's teaching and research interests includes NCD prevention and control in LMIC, and also includes implementation science research, health policy, and system strengthening, migration, and health. Finally, we also have Dr. Sohail Reza Chaudhary, who is a professor of epidemiology at National Heart Foundation Hospital and Research Institute based in Bangladesh. Dr. Chaudhary's area of expertise includes cardiovascular disease epidemiology and tobacco control. So it will be roughly around 45 minutes presentation, followed by question and answer. And we will really urge what Valerie mentioned at the beginning. There is a small hand icon you can see where you can press it, and we will give the floor to you to ask questions. But at the same time, there is a chat box there. So as speakers will be presenting, if you want to raise a question for particular a speaker, please type it in the chat box, and we will take all the questions at the end of the presentation. So with that note, I will request Dr. Abdullah to start the presentation.
Thank you, Sangeeta, for the introduction, and I want good afternoon and good evening, everybody who is on the line. And this is my great pleasure to be on this webinar today. And I don't want to talk much about this background. I think Sangeeta has described this very clearly, how timely and how important the topic that we are going to talk today. So with that brief note, I think I'm going to go with this talk that engaging community health workers in the management and prevention of non-communicable diseases in Asia, strategies, practices, and approaches. And I have my colleague with me, so I'll be start the talking first with some background information, and then my colleague Dr. Rao will be moving to joining me to talk some of the result part, and then Dr. Sohel Raja Chaudhary will be joining me at the end to discuss the summary of our study. So again, we all are happy to be here, and I want to emphasize at the beginning of our talk is that what we are going to talk today is based on a study we completed in 4 countries in the Asia Pacific region. We call this study as a combating non-communicable diseases in Asia by engaging community health workers in the management and prevention efforts, strategies, approaches, and practice. In brief, we call that quote study. So the findings of this study is already published by the APO in a policy brief. You can see the left side. There is the publications is published in early of this year. Is the use of community health workers to manage and prevent non-communicable diseases. So the talk we are going to present here today is heavily dependent on the policy brief that many of you might have already got a copy of this or downloaded from the APO website, and so is mostly based on the findings we have written on that policy brief based on our coach study in Bangladesh, China, Nepal, and Vietnam. So to give everybody a brief background of course, we know the NCD has become a global public health concern in the during the last decade, and is becoming more and more a health concern for many countries in the world, especially in the LMICs. As NCDs is accounted for about 73% of the total 56 million global deaths in 2017, and of those, cardiovascular diseases, cancers, chronic respiratory diseases, and diabetes was the major 4 NCDs that are causing all these deaths. And we also have there's also evidence from the global burden of disease study that there have been a percentage changes in major NCDs death. You can see there have been an increase of 87% of diabetes-related deaths, 24% of cardiovascular diseases, and 38% of the cancer-related deaths. And of the total NCDs in the world, about 77% is total 76.8% of all those NCDs actually occurring in low and middle income countries. Many of these 4 countries all fall in these LMICs, including many other countries in the Asia Pacific region. So this is a major problem, not for only these 4 countries, but for many LMICs in the world. And so in this slide, we talk about this burden of NCDs in the 4 countries. The data suggests that the proportion of mortality due to major NCD conditions has increased substantially in all 4 countries between 1990 to 2017. The proportion of disability-adjusted life years due to NCD has also increased, as you can see at the bottom line. Daily due to NCD has also increased on all these countries between 1990 to 2017. Just to give an example, we can see all NCDs in Bangladesh was covering 31.4% of deaths in 1990. Now that moved to 70.2%. And Vietnam, it was 62.4%, and now in 2017 it was 79%. So NCDs has become a major cause of death in these countries and many other countries. And in this slide, you can see that the non-communicable diseases also has how is getting a global priority, how United Nations, how WHO, and how the APO now is helping also pushing agenda for NCD control. In this slide, you can see that then UN Secretary General Ban Ki-moon, in his report to the 2011 UN General Assembly, highlighted the growing global threats from NCDs and acknowledged the importance of NCD control, and also suggested for good actions that countries should take to mitigate the burden due to NCDs. Since then, UN also has supported relevant programs across the nations, and including WHO is also taking some initiatives. And NCDs included in the also 2030 agenda for sustainable development and goal. You can see that I think everybody are very concerned about the SDG achievement, and goal 3 is good health and well-being. And under this SDG agenda, there have been a number of sub-goals was related to NCDs. For example, SDG 3.4 was mentioned by saying by 2030, with the reduced by 1/3 premature mortality from non-communicable diseases through prevention and treatment and promotion of mental health and well-being. So that is one. Other one is mentioned 3.6 SDG agenda by 2020, that's actually next year, halve the number of global deaths and injuries from the road traffic accident. And also was mentioned is that 3.A, to strengthen the implementation of the WHO Framework Convention and tobacco control on all countries as appropriate. So this is getting as a more upper level United Nations level priority, and to achieve the SDG goal, I think NCD related activity, NCD related prevention and control, and reducing the mortality and morbidity related to NCD is becoming a priority globally and also nationally. And so this is a global health and well-being third. And with that one, how the WHO is following that mandate. You can see that the two leaders from the two UN organizations were united to fight against NCDs, and WHO has taken several initiatives. You can see from the circles that is beginning on the top left-hand side, you can see WHO program for NCDs started to support countries with policy advice. The WHO Global Action Plan for NCDs that also started to support countries with latest knowledge and evidence-based information dissemination. WHO Global Monitoring Framework also started to support countries to set national targets, taking into account that 9 global targets and also other outcome indicators and progress indicators. To support that, they also started WHO Global Coordination Mechanism to support countries to facilitate collaboration between governments and other partners. UN also started UN Task Force for NCDs with the aim to support countries to mobilize sectors beyond health. So all these activities were mandated or initiated by the WHO to support the countries to set national targets, develop national action plans, and monitor results with the aim to combat the NCD-related burdens at the country level. So then in this slide, we can see that how NCDs prevention and control efforts in LMICs is happening in the low and middle income countries. We can see that many countries in the Asia Pacific region have healthcare systems that are designed to deal with maternal and child health and communicable diseases. However, in recent years, some countries have taken a variety of initiatives to address this growing burden of NCDs, including formulation of NCD multi-sectoral action plans, development of national NCD guidelines, and action plans for the prevention and control of tobacco, harmful use of alcohol use, and other health promotion activities. However, many of the low and middle income countries in this region have also started phase-wise implementation of the WHO package of essential non-communicable disease interventions for primary healthcare to support within the given healthcare systems. However, I think different countries have different strategies, some using in a pilot basis, some using that PAN program at a different level or in combination of other programs they already have in place. However, one thing we have identified, the innovations within these countries was that to include engaging community health workers for NCD management and how that could be support their primary healthcare system and have been examined. And engaging community health workers for NCD prevention and control have been going on for, not for NCD, but overall use of community health workers for health promotion activities have been in use for many years. But for NCD, it has become a new issue. And globally, community health workers were working for mostly communicable diseases, HIV prevention and care, reproductive health, child health and immunization, and delivering different primary health care services. However, in recently, of course, there are a lot of community health workers, a lot of programs across the countries started engaging community health workers for NCD prevention and control. A recent systematic review by JIT-EPL showed the potential of engaging community health workers for primary prevention and NCD risk factors in LMICs. In that study, they reviewed studies conducted number of LMIC countries covering different aspects: smoking cessation, hypertension management, also diabetes or HbA1c diabetes control, or healthy physical activity, and different programs that are supportive of NCD management. And they looked those outcomes and they found that actually making contribution those programs that engaging community health workers. Besides those that is reviewed, there are also other evidence from other studies. For example, nurse practitioner or community health worker-led intervention reduced cardiovascular health disparities in a study led by LMICS. Community health worker-led community-based intervention improved blood pressure in low-income developing country setting, as a study Jafar et al. Conducted in Pakistan and Bangladesh. Community health workers-led intervention for household smokers reduced secondary smoke exposure among children in China, is led by Abdullah and others. Also, another study conducted by Mash et al. Also found that diabetes group education led by community health workers improved behavioral and health outcomes in underserved communities in South Africa. So, and other study also showed that task-shifting intervention for common mental disorders in India improved mental health and health outcomes. So this gives us some background on how community health workers are contributing in varieties of NCDs, from NCD risk factors, smoking, tobacco, to mental health, to the disease-specific and hypertension, diabetes. So they are already making some evidence that community-based, community health worker-led intervention could be successful or could make a better outcome to control or manage these NCDs. So in this slide, with this background, now I come to the study, the original coach study that we have conducted in these 4 countries. So the aim of the objectives of our study is to examine the full range of programs for NCD care provided by community health workers in the Asia Pacific countries, and also to review the implementation process of these community health worker-led programs operated in 4 selected Asian countries. Our aim is that by doing this study, our aim is to identify facilitating factors and barriers for engaging community health workers in the delivery of NCD-related services within the primary healthcare system in these countries now have, and how they could be actually integrated, or they could become a part or become a recognized members of this primary healthcare system. So that was we explored through this study. And Next, I'm going to briefly mention that the methods we used for this study in these 4 countries. We use multi-pronged strategy for data collection, including situation analysis through the literature review. That included overall Medline, PubMed, and also Gray Literature's report in those country level, and also consultation with relevant organizations or personnel working in this field. We had stakeholders meeting in the country level policy discussions. We had 6 country level discussions among different stakeholders in this country. We also hold 2 multi-country meetings to get different policymakers, academicians, and community health workers together to understand the issues that could be addressed. We also conducted in-depth interviews of community health workers, health managers, and policymakers, and to identify the issues that we want to address. And we also conducted focus group discussions to collect country-level data to identify the common issues, common themes that could be considered by the policymakers. And so, with that methodology, we have come to a conclusion what our findings, what our results, and so we have found that community health workers is a term have been used differently by different countries. That so Bangladesh, they have different names. They have Sastha Sevika, Kormis, and community healthcare provider, family health care assistant, health inspector, assistant health inspector. While in China, is simple community health worker or village doctor, who are in the rural settings. In Nepal, they use health assistant, community medical assistant, auxiliary health worker, female community health volunteers. In Vietnam, mostly they call village health workers. However, the role of community health workers within the primary health care system, specifically for the NCD prevention and control, is not defined. It depends that in all those different names they are using, sometimes some of them have been engaged differently, some have been just doing it extended work, but overall their role is not very specified within this primary healthcare setting. And we have also found that they are also receiving different kind of education or training across these countries. In Bangladesh, for CHWs, they get about 12 weeks of training. And also, while health inspector, they get about 3 years of training, and then they can provide that kind of services. In China, is a very specific or well-developed program. They have a 3 years of junior college plus 1 year of practice-based training in the community center, and then they need to have also kind of continuous education program time to time to maintain their status. In Nepal, is overall those 12 months to 3 years, those who are health assistants and others, but mostly the rural setting, they have plenty of female community health volunteers. They have received few days training to few weeks, depending on the programs they will be working. In Vietnam, usually they have a 6 weeks training program, but also they have received training program specific from time to time, and the need of that program, they'll be providing services. So with this background information and with this initial background of community health workers, then our next move is to describe what we have found in this study, and based on our in-depth interviews, based on our stakeholders meeting, and all those approaches we use, how we summarize our findings. And we summarize our findings in different themes, and then I am now passing my next part of the presentation to my colleague, Dr. Lal Raul. So he'll take over from now to describe the result section that we have summarized under 5 major themes. Raul, please.
Professor Abdullah, thank you very much. So the results that we obtained from the qualitative studies, the study identified different aspects of the community health workers' potential of using the community health workers for the NCD prevention and control, and the findings are summarized under the 5 major themes. It includes general health-related programs delivered by the community health workers, current role, and delivering the non-communicable disease-related services. The third theme includes perceived barriers to expand the role of community health workers in the delivery of NCD-related services across these 4 countries. And the fourth theme includes perceived facilitators to expand the role of the community health workers in the delivery of NCD-related services and care. And then the final theme includes the willingness of the community health workers to engage in the delivery of the non-communicable disease-related services across these 4 study countries. Next slide, please, Abdullah. Yeah. The first theme about the general health-related programs. The following are the common programs being implemented being delivered by the community health workers in these 4 countries, and that this includes basic health record documentation, health education for maternal and child health care, integrated management of childhood and illness, reproductive health and family planning services being provided by the all community health workers, recording, reporting and treatment of infectious diseases, for example, tuberculosis, HIV, and also the programs includes the expanded program of immunization. These all are being delivered by the community health workers across the 4 countries, nutritional education and micronutrient supplements, health education and counseling services, as well as treatment of minor ailments, first aid and injuries. However, only for China, the emergency services is being provided in China by the community health workers. Theme 2 includes the NCD-related services being provided by the community health workers in these 4 countries. This includes the basic health recordings and documentation, which are being implemented by the community health workers across these all 4 countries. Usually, they are done in general health services, but NCDs are now being included. The second one includes the screening for common NCDs, especially the hypertension and diabetes screening services are being implemented or being delivered by the community health workers across these 4 countries. However, in the case of Bangladesh and Nepal, it includes especially where the specific programs are being implemented. For example, in Nepal, now the package for essential non-communicable disease prevention and control being implemented, being piloted in some districts. So only those districts, those screening services are going on. The other includes the diagnosis and basic management of common NCDs, especially the hypertension and diabetes. These services are also being implemented across these 4 countries. However, again, they're similar as the previous one in Bangladesh and Nepal. It depends on where the programs and where the pain package are being implemented. The other one includes the improving medication adherence programs. These programs is being implemented primarily in China and Vietnam, and again, depending on the programs being implemented, especially for Vietnam. And health education and counseling services, especially promotion of physical activity, tobacco control. These programs also are being implemented by the community health workers across these all 4 countries. The salt intake reduction, the education for the salt intake reduction is being implemented being delivered by the community health workers in China and Vietnam primarily. Mental health screening. So those community health workers who are providing or delivering the NCD-related services in Vietnam are also doing the mental health screening services. And then the final includes the documentation of the NCD-related services. Whatever services the community health workers are implementing, so they are also documenting those services and also reporting to the health management and information system. The third theme includes the perceived common barriers. So we also collected the information from the community health workers as well as policymakers in terms of what are the perceived barriers they think about potential for engaging the community health workers for the NCD prevention and care services. And we have categorized those perceived barriers into the 3 different levels: personal levels, organizational level, and the policy or system level. So at the personal level, the health workers identified that no specific job description on NCDs. So despite they are providing the NCD-related services, however, there are some issues in terms of not having the specific job description on NCDs. And the second one includes the limited training and education. So this is also the perceived barriers on implementation or delivery of NCD-related services, and that was being identified across the 4 countries. Lack of motivation, respect, and recognition. Despite the current possibility for using the community health workers for NCD is increasing, however, they also perceive that there are also some aspects of lack of motivation, respect, and recognition. And at the organizational level, imbalance, workload, and incentives also was identified as one of the perceived barriers. So that was identified in Bangladesh, Nepal, and Vietnam. However, the community health workers in China did not think that was a perceived barrier. And no integration within the healthcare system also was identified across these 3 countries, especially Bangladesh, Nepal, and Vietnam. And lack of basic resources and medical toolkit. So even though they are providing the NCD services, however, there were inadequate basic resources and medical toolkit for providing the NCD services. That was identified in Bangladesh, China, Nepal, and Vietnam. And no specific provision of payment to community health workers. No such specific provision for payment for community health workers, especially while they are providing the NCD services, was also considered as one of the barriers. No direct referral mechanism. For Bangladesh and Nepal, there has been some kind of programs for NCDs going on, especially in Nepal, the 10 package intervention, and Bangladesh, the program-wise NCD-related intervention as well. So that's why there are those districts where those NCD programs are going on. There are some referral mechanisms is being developed, being practiced. However, other countries, it is being identified that still there are no specific mechanism for the referral of patients. No authority to refill the prescribed medication was identified, one of the barriers in all countries, all across these countries. At the policy and the system level, perceived barriers were identified as policy priority, NCD guidelines, and standard operating procedure. So that was also identified as one of the barriers, and the other barrier was identified as inadequate program-associated resources and funding for NCD care, and also the community health workers not yet being part of the primary healthcare system was also identified. However, NCD-related services are going on, but still there's a scope of developing the NCD-related team at the primary healthcare level. Next slide, please. So having these perceived barriers and the services identified, also the community health workers and the policy level policy makers identified some of the perceived facilitators in terms of potential for engaging the community health workers or NCD services delivery across these 4 countries. Those include at the personal level, experience and learning capability. So community health workers are quite experienced, and also they have learning capacity and learning interest if the program is being introduced for the NCD services delivery across these all 4 countries. And interest and attitude, they are quite interested and have positive attitude in terms of being involved in the NCD services delivery. And welfare and benefits also was identified as the perceived facilitators if there is a provision of the welfare and benefits too. Close relationship with community, and also this was also identified as one of the perceived facilitators, because the community health workers have a very close relationship with the community people, and it is going to be quite easier for them to work with them and also implement the NCD-related services. societal recognition and respect. So if they are given the opportunity to deliver the NCD services, that also societal recognition, that also will identify as a, or maybe facilitate to societal recognition and respect, and that will identify across these 4 countries: Bangladesh, China, Nepal, and Vietnam. At the organizational level, so also the facilitator, perceived facilitator were the training opportunity. If there are some training opportunities, that will facilitate them for implementing the NCD-related services. That was identified across these all 4 countries. And balanced workload and provision of incentives. That is also another perceived facilitators. If there is a balanced workload, provision, and incentives. And in addition to that, community health workers also identified that there needs to be the official recognition and as well as supervision and the support from the systems level. And resources for medical kit and resources for providing the NCD services needs to be provided or needs to be adequate so that they could provide the NCD services. And that was also identified as one of the perceived facilitators. Supportive working environment, that was identified across all 4 countries. So at the policy and system level, some of the perceived facilitators were identified as government across all 4 countries have given the priority in terms of integrating the community health workers for NCD care within the primary healthcare system. And China has already started. China has already started at the policy, at the systems, and as well as the implementation level for providing or delivering the NCD services by community health workers. And all 3 countries also identified as one of the facilitators for incorporating or engaging community health workers at the system level, at the policy level. And another also facilitator was identified as bundling the select NCDs with model health program. So all these countries have some level of experience in terms of engaging the community health workers for providing the services. So there is an opportunity to bundle the NCD services within the ongoing health programs as well. And then allocation of adequate funding. So funding is always very important. Unless there is adequate funding, it's going to be quite challenging to implement any services. So that was also identified as one of the facilities. The theme 5 includes the willingness to engage in NCD care. So community health workers identified that upon receiving the training, especially focused on the NCDs, they are quite willing, they are quite interested to engage in providing the NCD services, including routine screening, early detection for hypertension, diabetes, and mental health services as well. So overall NCD services, however, more focused on the hypertension, diabetes, and mental health. So NCD risk reduction counseling for high risk and general population, not only providing the services at the clinic level, at the health facility level, also they are quite interested in going to the community and providing the health and counseling services for the NCD risk reduction at the population level, at the community level. And also they are the willingness was to provide the referral services to the different health facilities. So at the policy level, the policymakers suggested that it is quite feasible to train and engage the community health workers in the primary care for NCDs. So given the policy emphasis, given the programs, given the systems, so there is feasibility, there is quite possible to train and engage the community health workers in primary care for NCD prevention and control. So there is also the potential for integrating the community health workers in the primary healthcare systems with multitask. So especially not only just simply providing the NCD services, however, those community health workers who are providing the services, that also could be included the NCD-related services. Also, there could be testing a standalone model of NCD-specific community health workers. So there is also a possibility to test just standalone the independent, the NCD-related model, whether that model will work or not, or whether that model will show the efficacy or effectiveness or not in terms of providing NCD services. That is also the possibility. And also testing of NCD training model to build capacity for community health workers. Also, the policymakers acknowledge that inadequate incentives available for community health workers. Despite having this policy level, system level, and all emphasis, and then the priorities, they also acknowledge that there is still the inadequate incentives available for CHWs, and also the another willingness was identified as fixed financial resources within the annual budget. So every country has the annual budget, provision of annual budget. So there is a possibility, and the government could identify and allocate the fixed annual budget for the central level and district level, especially for the NCD services delivery in the country. So here, I would like to conclude my presentation, and I would like now to invite the Professor Sohail Raja Chaudhary to present the rest of the part.
Okay, hello everyone, and thank you, Dr. Rao, and also Dr. Abdullah for presenting the background and also the findings of our study. So, by analyzing all our findings and the reports, we have actually come up with several policy options for countries to consider, and these are that the countries need to consider the country-specific contextual factors for the development and implementation of NCD programs, and countries also need to prioritize the building capacity of community health workers with a focus on NCD prevention and management within the existing primary health care system that they have at this moment. And countries need to recognize the central role of community health workers within the primary health care program through the provision of incentives, welfare, and career path. And most of the countries in the community health workers actually mention about the inadequate incentives and also the lack of the career path. And this is one of the important things came up from our findings. And countries should consider adaptation and or strengthening of WHO PEN for prevention and control of NCDs, and a stepwise or phase-wise implementation of WHO PEN would be a good way of integrating NCD in primary healthcare systems. So, in summary, we'd like to say that there is a potential for engaging community health workers in delivering community-based NCD services in Asia, but there is a need to strengthen community health workers' capacity to deliver NCD services, and also there is a need to restructure and enhance the primary healthcare system to include NCDs. Next slide, please. Okay, well, I'd also like to end by acknowledging our partners, like the Global Health Institute from Duke University, Professor Shen Lang Tang. We had also worked with Hanoi University of Public Health, Dr. Huang Van Mien and Ms. Tran Chit Han, and on the country team. We worked with Heart International of Nepal, Dr. Sushil Boral and his country team. Fudan University of School of Public Health, China, Dr. Li Jian and Tao Sha. We also work here in Bangladesh National Heart Foundation Hospital and Research Institute of, that is Dr. Samir Zubair and his team. We also issue research support staff from Global Health Research Center of the Ocean University. And also we'd like to thank the heartfelt gratitude to the participants in the stakeholders meetings, interviews and focus groups. Thank you.